clearly a path to sustainability. We had a number of discussions internally about this. One of the things that some of the critics of the system would like to say is that we didn't have plans on how to be sustainable. But the fact of the matter is, if you look at the way the LSU system is structured today, first off, you've got the components of an integrated delivery system that the federal reformers are looking for. And so we felt like we had those components. So when Medicare starts paying differentially for, are you having good quality metrics within your hospital? Are you having problems with readmissions and things like that? We could control that better because we've got the doctors and the hospitals working together as one. And so from the delivery system perspective, we have the kind of system that you see others moving towards, trying to create scale so you can support things like big IT projects. So we felt we were on the right track there, and in fact ahead of the game there. On the financial side, we have a large percentage of the business that's paid for through the disproportionate share program, and about half of the patients in the system are uninsured patients. And what you would be doing with the Medicaid expansion is you would be moving probably 2/3 of those people from the uninsured category to the Medicaid category. Now, with the state match for the disproportionate share program today is roughly almost 40%. The state match for the Medicaid program for the expansion population, where you'd be moving the uninsured, would be 0 for the first 3 years, and over the next 3 years it tapers off to 10% state match, 90% federal. So you're moving from a uninsured DISH funded program where the state's putting up 40% to a Medicaid program where at its peak the state's going to be putting up 10%. And in that Medicaid program, Medicaid pays for physicians. The DISH program does not pay for physician services. So from the school's perspective, the physicians are providing that care. Now you have a funding source for those physicians as well. And so we had intended to have a very aggressive strategy to enroll people, to shift them from that uninsured category to the Medicaid category. It would be better for the state, better for LSU, and clearly would provide a funding source to sustain that operation. And so you would sustain an integrated delivery system that's well versed in taking care of the uninsured, provides good care, and would be able to do it at a lower cost to the state. There will be ultimately some reductions in the disproportionate share of funding for the state. I know Secretary Greenstein has said, we have a big cap, and so we can absorb a cut. I don't think that's how it's going to be done. I think that the federal score is to have savings, and so they're going to take it from a baseline year of spending and give you your cut from a baseline year of spending. And so there will be some impact on the DISH allocation for Louisiana, I'm quite sure. How it's going to be up to the state to determine how they deal with that. You got rural hospitals that depend upon those funds. You've got some of the state psychiatric hospitals that depend upon those funds, and then community hospitals as well, all in addition to LSU. Mm-hmm. The legislature or the administration is going to have to figure out how they want to deal with those reductions. As I said, LSU, I think we would have been in the position to absorb some reduction in DISH. In fact, would have embraced that, because we would have ensured that those people got shifted over to the Medicaid program, could take a DISH cut and the increased funding that goes along with the Medicaid program. You can't reject the Medicaid expansion. You're still going to get the DISH reduction. CMS is going to make some rules around DISH reduction, and I would doubt that they would look at a state that rejects the Medicaid expansion and then protect you from a DISH reduction because you have more uninsured, because you obviously have at your disposal the option to increase Medicaid to deal with your uninsured.
Right.
The other thing about that is if you reject the Medicaid expansion, the federal government is still going to provide subsidies for people between 100% of poverty and 400% of poverty to purchase insurance. So be a graduated subsidy for people between 100 and 400% of poverty. Now, their assumption in that design is that Medicaid is going to cover, the Medicaid expansion goes up to 139% of poverty, that Medicaid would cover those people below 100% of poverty, and so you wouldn't have to do a subsidy for those people to purchase private insurance. It would be covered through Medicaid. Well, if the state rejects the Medicaid expansion, what you'll have is you'll set up a scenario where those below 100% of poverty will not be eligible for a federal subsidy to purchase insurance and will not be eligible for Medicaid, so they're going to be stuck in that uninsured mode.